We'll be getting started in just a few moments. Hi, everyone, and welcome. I'm Liz Whitehead, Managing Editor at U.S. News and World Report. Thank you for joining today's webinar, Breakthroughs in Pediatric Cancer Treatment, A Path Forward. Our experts will discuss advances in pediatric cancer care, including CAR T-cell therapy, genetics, and precision medicine. Today's session is the first in our special Pediatric Priorities virtual event series, where we explore what children's hospital executives, pediatric providers, and key community stakeholders can do to improve the well-being of America's young people. You can learn more about programs happening this month and next at usnews.com/pediatric priorities. We are recording video of today's session and will be archiving the video on usnews.com. We are also simulcasting on Facebook, LinkedIn, and YouTube. Before welcoming today's panel, one final note. If you have questions, we ask that you please type them into the Q&A feature in Zoom on your screen. Later in the discussion, our moderator will try to give voice to some of these as time allows. Now, I'm pleased to introduce our outstanding panel. Dr. Andrew Kung, Chair of the Department of Pediatrics at Memorial Sloan Kettering Cancer Center. Dr. Mignon Lo, Division Chief of Pediatric Hematology, Oncology, Bone Marrow Transplant, and Cellular Therapy at Seattle Children's. Dr. Will Parsons, the Sidney L. and Donald F. Faust Chair of Pediatric Cancer Precision Medicine at the Cancer and Hematology Center at Texas Children's Hospital. And Dr. Charles Roberts, Executive Vice President and Director of the Comprehensive Cancer Center at St. Jude Children's Research Hospital. Now I will turn the mic over to my colleague, Michael Morella, Managing Editor at U.S. News, who will moderate today's discussion. Michael?
Thanks so much, Liz, and thanks to our audience for joining us and to our panel for being with us today. Now, panelists, you all represent some of the leading pediatric cancer programs in the country. Could we just start by going around the horn and each of you briefly talking about your background, your specialty areas, and your institution's reach? Dr. Kung, could we start off with you?
Absolutely. Well, thank you for the welcome. I'm the chair of pediatrics at Memorial Sloan Kettering, and my path to pediatric cancer, pediatric oncology sort of wound through Boston, where several of the panelists trained and helped train me, through to Columbia about 10 years ago, and more recently here to Memorial Sloan Kettering. And really all along that path, it's really been a pleasure to see the growth of the field and the evolution of pediatric cancer care into a more personalized and precise approach, which I think will be the subject of discussion today.
Dr. Lowe, how about you?
Sure, thanks for that introduction. So I also spent some time in Boston. I'm slightly embarrassed to say that I did. I think I was a few years ahead of both Andrew and Charlie, though I think we're about the same age because they're smarter than I am and they took extra time to do their PhDs, and I do not have a PhD. I then spent about 20 years at the University of California in San Francisco, where I also led the division in hematology and oncology. And then very, very recently, just in December, made the move to Seattle Children's Hospital, which really has an extraordinary program and is built for some additional growth. So I'm very excited to be here and to discuss a number of topics with you all today. On a national level, I'm the chair of the Acute Lymphoblastic Leukemia Committee of the Children's Oncology Group. So I have a hand in developing, supervising, and executing the ALL trial portfolio for children who are treated at COG institutions who enroll on COG protocols. So thank you.
Thank you. Dr. Parsons, how about yourself?
Sure. I'm Will Parsons. I'm a pediatric oncologist and cancer genetics researcher. I did my MD and PhD at The Ohio State University in Columbus, Ohio. Then did my pediatrics residency and hem-onc fellowship training at Johns Hopkins and the National Cancer Institute. I've been down in Houston at Texas Children's Hospital and Baylor College of Medicine since 2008 to 2009. I play a number of roles here, but similar to several of the other folks on the call, my research focus has been on the clinical application of genetics and genomics for childhood cancer patients. So both what we can learn about cancer biology through genetics, but then just as importantly, how we can apply that to our patients. So in recent years, spent a lot of time collaborating with our multidisciplinary team on clinical genomics trials and trying to understand how to most usefully use genetics to take care of our patients and their families, how to implement that, how to use it for diverse families and patients in diverse clinical settings, and then running clinical trials through the Children's Oncology Group and elsewhere of kind of precision oncology, genomic medicine, whatever you'd like to call it. So it's a delight to be here. Thanks.
Thank you, and we'll come back to a number of those topics in just a moment. Dr. Roberts?
Great. So thanks for the invitation. So I'm a pediatric oncologist. Like several other people mentioned, I trained in Boston at Boston Children's Dana-Farber, and then 6 years ago was recruited to St. Jude Children's Research Hospital as Cancer Center Director and Executive Vice President. You asked about our institutions. So St. Jude's the only comprehensive cancer center that is dedicated exclusively to children. And so we have 150 faculty that are working on that. And collaboration, as I think what we may touch on, is just essential. And so we very much enjoy collaborating with the institutions that are represented here and many more as we bring impact to childhood cancer.
Wonderful. Thank you, Dr. Roberts. Thank you all. Now, our audience includes a lot of pediatric practitioners and leaders from different fields and different institutions across the country. Very briefly, I'd love to just give them a sense of how the pandemic impacted cancer care for children. I've heard from a number of you that it is generally the case that missed screenings or diagnosis has maybe been less of an issue than for adults who missed a mammogram or colorectal cancer screening. Do you agree with that perspective generally, or has the pandemic delayed or set back research, clinical trials, treatment, things like that?
I'll hop in. Screening is much less of an issue for childhood cancer. What it has had an impact on, so we've been able to enroll patients to therapeutic trials, which is great. But the non-therapeutic trials, the survivorship, as we're 500,000 survivors of childhood cancer trying to learn more of how we can do better for their health, those ground to a halt because we couldn't have patients on campus without giving them therapy. One upside that we did have is we did launch a virtual series on the science of childhood cancer, which was great. In fact, Dr. Lowe was one of our speakers. We got kicked off by someone from Memorial Sloan Kettering. And so bringing people together nationally, internationally has been, I think, a bright spot in an otherwise challenging environment.
Our experience has been similar in that the kind of core mission of taking care of our patients, it's actually been pretty amazing what the partnership between the clinicians, the staff and our patients and their families has been able to do in terms of keeping everything moving in terms of basic clinical care. And the same really for clinical research and trials. We've maintained, enrollment on trials and especially therapeutic trials over this time. So anything related to the direct care of our patients. The challenge has been more in some of the other activities, some of the the research projects and the things that are not directly related to patient care. But as Dr. Roberts kind of mentioned, it has inspired, I think, some new thinking about how to remain connected and how to, through virtual means, through other kind of contacts, both with our patients, their families, and for our staff and our teams, how to keep connected over the pandemic, which I think has been pretty useful.
I think in New York, we were clearly deeply impacted during the first wave. But then, like the rest of the institutions, I think have really evolved the way that we practice to one that really portends how we are going to live with COVID for probably a very long time. And as Will and Charlie pointed out, that ability to accelerate our move into remote connection, both with our colleagues, but also the delivery of care through remote means is something that has been supercharged by the pandemic. And that ability to bring care closer to where a patient lives, I think will be a long-term trend that will continue even as we emerge out of the heights of the pandemic.
I would definitely agree with that. That's been a silver lining, I think, in this pandemic, is the ability to do telehealth visits with patients who travel from far away. I can say, confidently in Northern California, we see, when I was in Northern California, we saw a lot of patients from very far away. And pre-pandemic, it was challenging to get them in for off therapy visits, et cetera. So that's one silver lining for sure. I would say early on in the pandemic, we did see some patients who were delayed in presentations. So we did perhaps see a few cases of sort of more advanced solid tumors than we might otherwise have seen if it was not for the pandemic. But overall, the enrollment to our ALL trials has remained steady, which is surprising. And the impact of COVID-19 in that population has been relatively minimal, surprisingly. So we're getting through it. I would say that the hit's been substantial to the healthcare providers, though, covering for each other when they're out with COVID, the unexpected absences, both on the nursing staff and the physician staff. So I'm looking forward to the day when I really don't have to, have that continued. So, but yeah.
Well, I thank you all. Predicting the future is impossible, but I do want to be a little bit forward-looking and dig a little deeper into some of the advances in pediatric cancer care, where things stand today, of course, but where things might be in, say, 5-10 years from now. You all teed up a number of different topics, but I'd love to start with immunotherapy, which really has emerged as a groundbreaking pillar of care for many people. Anything exciting going on in your own research at your own institutions or in the field at large that you could share with our audience?
Well, I'll just start a little bit, just because I am a bit of a newcomer to Seattle Children's, so I'm sort of still feeling like I can be an external judge of this. But Seattle has actually been a huge player in this immunotherapy field through collaborative work with a number of investigators led by Julie Park and Mike Jensen. The Seattle Therapeutics Initiative has resulted in us treating over 400 patients actually with some interesting novel CAR product here in Seattle. And I think that pushing the envelope of the constructs that we're testing in leukemia, solid tumors, and brain tumors is definitely a priority for our institution. And I think it reflects a tremendous amount of collaboration, again, across the hospital with scientists, and is really a fabulous example, wherever you get your CARs, of translational medicine. For us also on a national stage, I think one challenge is how we partner effectively with pharmaceutical companies to actually rigorously test some of these products in even larger populations. And so that's just one thing I'll throw out to maybe my other panelists to see sort of their views as well. Thanks.
I think, we've at Memorial Sloan Kettering have been involved with CAR T-cell development for many years. But as we think about immunotherapy, I think the opportunities that exist for children with cancer really need to expand beyond that. And as much as there have been successes and striking successes with CAR T cells in liquid tumors, better understanding how to use CAR T cells for some of the solid tumors, I think, represents an area that we need better traction in. And then there's a whole another type of immunotherapy, or many other types of immunotherapy, one of which are so-called checkpoint inhibitors, the type of immunotherapy drugs that take the brakes off T cells, for example. And those are therapies that have really moved the needle in several adult cancer indications, and less so in pediatric cancers. And that probably is because of the differing biology in terms of what drives pediatric cancers. But the existing immunotherapies really only address a couple of the classes of brakes and accelerators that can be used to modulate the immune system. And I think a major opportunity for us in pediatrics is to better understand what are the more pediatric specific targets in the immune system that we should be pushing on. And that gets back to the notion that pediatric cancers are fundamentally different in many ways than adult cancers. And so becoming more precise in how we modulate the immune system in a pediatric cancer specific way, I think is a real opportunity that we're all somehow connected to on this panel.
I agree with Andrew. The checkpoint inhibitors have largely been low impact in childhood cancer, with very few exceptions, the high mutation rate. The CAR T has been very exciting. Seattle, Sloan Kettering, Baylor, all having impact. Michelle Mongi, Robbie Meisner and Crystal Makel at Stanford also doing some really nice work in solid tumors. It's been a major focus for us at St. Jude. Dario Campana here built the innards of the first CAR T, ultimately what was used in the CAR T that's curative for ALL, and the anti-GD2 antibody, also from Sloan Kettering. St. Jude moved it up front into therapy for neuroblastoma and has gotten some very promising results from that. And we're excited to work with the Children's Oncology Group now for large-scale testing of that impact. So it is important, but it's also significantly different than adult cancer immunotherapy.
Yeah, I think that's a key point. I'm thinking back about this, it actually makes me feel old, but just reflecting on the change from over my time in training to now of these immunotherapy approaches being theoretically very exciting and incredible science, but not yet something that was in the clinic, to something that's shown incredible promise for specific hematologic malignancies, to now something that we've started to see some of the first signals of success in terms of treating solid tumor patients. And so, you know, here, like all the other institutions we've been talking about here at Texas Children's and Baylor, our folks in our Center for Cell and Gene Therapy have really been focusing on this as well. Specifically, I guess I'd highlight a couple points. One being CAR T cells being one area of focus, but other immune cells and effectors such as natural killer or NK cells, other kind of means of activating the immune system have really been an area of focus. I think the other kind of interface or real current challenge is trying to figure out how to make this useful for children with solid tumors. So brain tumors, other non-central nervous solid tumors where the tumor microenvironment is a challenge, access to the tissue is a challenge, and you know, there's a number of other practical things, but it's really pretty amazing to watch kind of collaborating a little bit, but mainly secondhand, kind of the step-by-step progress that's being made in terms of understanding the science of each of those things, and then slowly figuring, or well, relatively quickly, but we're always impatient, learning how to make progress in terms of each of those technical and biologic challenges. It's really actually an exciting time for all of this.
I wanted to add just one other comment also, you know, in addition to the chimeric antigen receptor therapies that have just been discussed and the checkpoint inhibitors, there are a whole nother sets of classes of agents in sort of immune modulating sort of therapies, including these bispecific T-cell engaging products like blinatumomab, as well as sort of toxin associated antibodies such as inotuzumab. And these are agents that we're introducing on a national level into frontline treatment for childhood ALL, with the hopes that at some point we can start backing off on like traditional cytotoxic chemotherapy and maybe substituting some of these other agents in there, which we know many of these can be even safer than chemotherapy. So again, this is another 5 to 10 years worth of research, but those are also goals for all of us as we try to reduce the acute and late effects of our chemotherapeutic regimens with some of these other agents.
Yeah, let's stay with that point, Dr. Lowe. Thank you for bringing it up. Are there things that your institutions or others you've seen are doing to kind of work to mitigate those toxic long-term effects of treatments on young people as they age? Anything else you could share about that?
Sure. I mean, I think that the field of survivorship is enormous. Again, because we're, because we're fortunate to not have that many diagnoses in pediatrics, we all band together. And the CCSG, I mean, there's so many opportunities to conduct large scale research, and Charlie already alluded to the tremendous survivorship program that they have at St. Jude as well. We also have a survivorship program at Seattle. And again, everybody is sort of working in concert to see what the effects are of some of our therapies and, how we challenge some of the paradigms that we've always thought, like what cumulative dose of an anthracycline actually puts you at a higher risk of cardiac toxicity. And in fact, it's probably a lot lower than we previously anticipated. So those are some of the sorts of things that I think people who are doing survivorship investigate, and there's many, many more as well.
Great points, Mignon. As I mentioned, there's 500,000 survivors of childhood cancer in the U.S. already, and with now 80% cure rates on average for childhood cancer, the number of survivors is growing rapidly. At St. Jude, we lead two of the world's largest survivorship studies, the Childhood Cancer Survivor Study and St. Jude Life, and so collectively we're following tens of thousands of survivors. Trying to really understand what are the impacts of treatment so that we can give them longer, healthier lives. A major focus has been the discovery by Carrie Ness and team of accelerated aging and frailty in survivors. And so trying to understand, as Mignon was saying, the impact of chemotherapy, how can we decrease it up front? How can we intervene before people get side effects? And increasingly, how can we ameliorate the side effects once they develop?
Yeah, I think there's a lot of great programs. I mean, obviously increasing recognition of this new challenge we've created by being more successful in treating childhood cancer patients, but common themes of early engagement with patients and families, of this being a key challenge and something that's going to be need to followed over time, lifelong follow-up, kind of some focus on adolescent and young adult specific kind of programming and efforts to make that transition between the pediatric and the adult world, standardizing kind of practice guidelines and referrals and kind of procedures for this sort of thing. So it's not the sort of deal that a adult, primary care physician is having to reinvent the wheel and figure out, what needs to be done for this particular, patient who was a very complicated pediatric cancer patient back in her or his day. So yeah, Texas Children's, we've had, again, kind of a program, a clinical decision support tool we've used called Passport to Care that tries to simplify some of these, recommendation referral guidelines. Now includes, I think, probably 50,000 survivors or so. But there's a number of different ways to do it, but really trying to make this a systematic part of how patients are treated and cared for the long term.
Yeah, I would echo those comments and just point out that it's not just about substituting immunotherapy for cytotoxic chemotherapy or limiting doses. In some cases, we've incorporated protectants, cardioprotectants into our treatment. But overall, I think, really becoming more precise in our approach to the patient is a general theme that helps get us to more not just precise, but targeted treatment approaches. And that's something that we've done in our field for a very long time. Risk stratifying, finding those patients that are not going to do well with the standard therapy and perhaps intensifying in those patients, but then recognizing that the ones who carry markers that would suggest they do well, actually starting to think about pulling back on the amount of therapy. Substituting more precise approaches, not only in terms of the drugs that we give, but also how we give radiation, for example. In some cases, we're able to do it in a more precise manner, using different types of radiation protons, for example. In some cases, substituting other treatments in place of radiation. So, so across the different treatment modalities, we have to pay very close attention to these children who we're trying to return to lives that are as normal as possible. And that extends beyond the purview of what we do as chemotherapists to also, for example, surgical approaches, limb-sparing surgeries when possible, minimally invasive surgical approaches. And so sort of decreasing and limiting toxicity, I think, is at the very core of what we all do as pediatric oncologists.
Let's go back to speaking of precision, precision medicine, precision oncology, that area. I'd love to talk a little bit more about it because I think most, if not all of you, that's central to a lot of the work that you and your colleagues are doing. Could you help us kind of unpack and understand that area, what some of the more recent intriguing work is? And I'd love to also hear how you're working to sort of translate some of that bench research to the bedside and even communicate some of the complicated genetic situations to individuals and families. Dr. Parsons, would you like to start us off there?
Sure. I mean, this has clearly been an area like immunotherapy of kind of focus and some of the cutting edge research. I mean, precision cancer medicine, I think we think specifically most often of kind of identifying changes or mutations in tumors and then picking molecularly targeted drugs and therapies to treat them. But I think if we think of it much more broadly, there's really been incredible progress, right? So it's basically genetics or learning about a patient's genetics and their tumor's genetics has started to impact everything we do in terms of taking care of our patients, right? From how we diagnose them, both in liquid and solid tumors. The various kind of classification of cancer types and stuff now include molecular information in addition to just, histology or what it looked like under the microscope that we already referred to in terms of risk stratifying patients and identifying patients who may need more or less therapy that we could either treat more safely or we need to treat much more aggressively. And then I think also importantly, understanding cancer's susceptibility and why some of our patients develop cancer and which of them and their families would benefit from additional testing, follow-up, and cancer surveillance. So I think we probably won't focus on it as much, but there's a lot in terms of precision cancer medicine that I think has become a fundamental part of what we do for our patients. In terms of thinking more about targeted therapies, there's been a lot of incredible research at the various institutions represented here and across, the Children's Oncology Group. We've focused, for example, here at Texas Children's on trials where we've been enrolling patients across the state of Texas, testing different types of clinical molecular testing, whether it be, exome sequencing, genome sequencing, transcriptome sequencing, et cetera, but then having a team that also, as you were kind of asking about, studying how we implement that, what our patients and families understand about it, how we can communicate these very complicated results most effectively and simply, and what the concerns and needs of kind of all the various stakeholders are, from patients and families and their anxieties or needs potentially related to genomic testing, as well as our oncologists and how we can best give information to them that allow them to treat their patient. So I think it's a really kind of multifactorial thing, and there's been a lot of cool research in the last decade in this front.
I can, I echo everything that Will said, although one of the things that has really been a challenge is while we're beginning to understand the genomes and the DNA mutations that underlie childhood cancer, in few cases are they directly targetable. Many of those genes are lost and are gone, or they're very complex to target. And so for the ones that exist, fusion oncoproteins has become a major area of interest. We have a team at St. Jude here thinking about, is there new chemistry that can do that? But this challenge is still going to remain for a lot of these mutations. So a very interesting project was set up by the Broad Institute, Dana-Farber Cancer Institute in Boston, the Pediatric Cancer Dependency Project. St. Jude is in the process of becoming a major partner there, but it asks a different question. Instead of what genes when mutated cause the cancer, what genes when turned off cause the cancer to die? And the idea there is to be able to find things that are druggable and move into the clinic quickly. It's early, but there's good and exciting proof of principle for that as a partner building off of pediatric cancer genome projects going forward.
Yeah, I think this is a really important point, that as we talk about precision medicine, we made a lot of progress on the precision side and less progress on the medicine side. And what Charlie was talking about is highly relevant right now because there is a regulatory change that really incentivizes, and not just incentivizes, but mandates that drugs being made for adult cancers, adult indications, must be tested in pediatric cancers if those cancers share a similar target. And so understanding what are the dependencies, the vulnerabilities in pediatric cancers using whether it's panel sequencing, whole exome, whole genome, as Will alluded to, is a really important set of activities right now, because I think there's been more movement on the drug side, on the medicine side, but it's incumbent upon us as a field to understand which diseases do you apply those drugs to. The regulatory framework to incentivize now testing those in pediatric diseases has been put into place. And so now I think is the time that we as a field have to come to the table with a better understanding of the biology and what are those targets that are most relevant to apply in pediatric cancers.
Yeah, I would definitely agree with what others have said. I think, at Seattle Children's, obviously, or at most places now, patients with higher risk tumors will have the availability of advanced genomic sequencing, and we're certainly no exception to that. And we've also partnered with the Brotman Beatty Institute at the University of Washington, and there's some exciting work going on there about how to actually validate, the kinds of alterations in your DNA that might not scream out, I'm a mutation, but might be a little bit uncertain. So that's pretty exciting work. But I think, Andrew's exactly right. The medicine is not completely kept up, but as it has kept up, I think the other challenge, which is huge, is how we do get access to those drugs. I know that there are these requirements now for pharmaceutical companies to test their agents in children and adolescents, but still getting access to them and doing it in a nimble and quick way has been challenging. Though Will had a tremendous opportunity to explore this with the Children's Oncology Group. I don't know, Will, I don't mean to put you on the spot, and Michael, you're the moderator, but I'd love, maybe you want to say a little bit about the MATCH study?
Sure, thanks. I mean, I think, you highlighted a really key word, which is access. So both access to kind of what we would consider, I think, discussing this call, state-of-the-art molecular profiling or testing, and then also access to the investigational therapies and kind of the cutting-edge drugs, right? And so making sure that those are both available, for all of our patients across the country, regardless of their proximity to one of the big cancer centers or that sort of thing. That was the idea. I think the access is the idea behind the NCI and COG partnered on the Pediatric MATCH trial, which is essentially a nationwide framework for testing targeted therapies in kids and young adults with refractory cancers. So basically a nationwide screening protocol that allows access to state-of-the-art tumor testing, and then a menu a kind of assortment, 13 different trials of individual targeted therapies, such the patient's tumor can be sequenced, that they have a mutation in a particular gene, then they can be enrolled on a trial of that's targeting that gene, for example. And it's, enrolled 1,400 patients so far. And it's really, I think, been quite successful in terms of the access. I think it does highlight, I think in some ways it's the culmination of what I would consider this first round or first stage of precision medicine in terms of therapies, meaning sequencing tumors, identifying a mutation or a fusion or a copy number gain that we can relatively easily interpret, or we think we can in terms of its biology, and then targeting it with single agents. But I think the previous speakers really highlighted the need for the next stage, right, which is understanding in a little more subtlety what the whole range of alterations are in pediatric cancers and what they might mean in terms of therapies and how we implement combinations of therapies. There's an upcoming, NCI combination MATCH trial, which the Children's Oncology Group will be collaborating on, and other initiatives. So yeah, I think access is one of the really key words, and Pediatric MATCH was one attempt effective attempt to make that more feasible.
It's such a good point, but there's also another piece of the puzzle. St. Jude, working with Children's Oncology Group, sequenced thousands of childhood cancers, some great work done in Europe as well. And it turns out that 50% of the mutations that are found in childhood cancer are not present in adult cancers. They don't occur. It's a different disease. And so the old trickle down from adults to kids is not going to work for these cancers because those mutations do not exist there. And so, as Mignon was saying about relationships with pharma and also regulatory, how do we go after these things in kids with cancer? They're rare. In many cases, there's not a huge profit unless we can de-risk this. But it's a really important endeavor where I think all of us need to come together to be able to think about these things and how can we de-risk these and incentivize pharma to get interested in these targets that matter to kids but are not found in adult cancers.
I want to just for a moment echo that question. You asked it earlier, Dr. Lowe and Dr. Roberts. Again, are there solutions at the policy level, maybe even at the state level, that you all have seen in your own backyards that are pushing things in that direction from a drug development standpoint, from clearing some of those barriers or hurdles or anything like that you can point to?
I think that regulatory can only take you so far. Our colleague Steve Du Bois recently published a study looking at the time from when a drug is first used in an adult and the lag when it's first used in children, and that's somewhere on the order of 6 to 7 years of a lag. So even with the incentives and the mandates that you have to go into kids, it doesn't solve that problem. I think one of the things that does help in terms of incentivizing work in the pediatric space is if we can define the biology that really makes it so that a particular drug, a particular target is most relevant or highly relevant in the pediatric disease. Because one of the things that is also true is that pediatric diseases are in general simpler, if you will, in terms of the number of things driving them compared to adult cancers. And so if there are opportunities to target something that is a central pillar to a pediatric cancer, I think we generally do get some traction, better traction, if it represents a highly enriched responder population for that drug. I mean, the other, I think, opportunity that we have to seize upon is new technologies, new approaches, new chemistry that comes about. And I think there's a lot of excitement on the research side of the translational spectrum around some of the evolving therapies that seek to degrade proteins in cells. It's a very different type of effect than most existing approved drugs. And there, it may be particularly relevant to pediatric cancers that are driven by these transcription factors and translocations that Charlie alluded to, where it's one dominant driver, that if we can address that one dominant driver, may have a very large scope of effect. But that's sort of in the future. It's not the here and now.
I'd like to bring in a question from one of our listeners briefly. It was alluded to earlier, telemedicine, and a lot has been discussed about how telemedicine has changed things and been so impactful in the last 2.5 years. Do you have any sense moving forward of whether that is really here to stay for cancer care, and how that can help bridge the gap with individuals and with families? Anything you can talk a little bit about how a virtual approach or a hybrid approach is really making a difference? Dr. Lowe, yeah.
No, go ahead, Dr. Lowe.
Oh, I mean, I think it's here to stay. I think that's a very clear outcome of this pandemic, and I'm glad for it, because I do think, when we treat our patients pre-pandemic, obviously we knew there were challenges to families who work. There were challenges on who would take care of the other siblings. There were so many challenges around just caring for a child affected with cancer. And so having this hybrid approach where people are seen because they need to get their chemotherapy, obviously at the infusion center in the hospital, but perhaps during in between times, having a telehealth visit or clearly during follow-up makes a lot of sense. So I think it is definitely here to stay. And I think that families really like it. I mean, I think that they like having the flexibility of doing this from home. Now, this also assumes that they have access to a computer with a laptop or something, and access to the internet, which is not universal. So I would just say that's something that's sort of currently still in progress, I think, across the country, but definitely helps.
Yeah, I completely agree. It's here to stay. The question is really, what are the technologies that would be simplest and allow everyone to use, as Dr. Lowe was referring to, in scenarios where not everybody has a computer, or not everybody has a particular kind of type of phone. For example, we've been interested in this in terms of our clinical genomic studies, right, where we're sequencing patients' tumors in their blood. We're identifying in some of them mutations that they've inherited, for example, or explain why they get the cancer, and how we return those results to families. Either positive or negative results, meaning either we find something or we don't. In our first studies, when we were doing this 10 years ago, was very formal, right? We'd do the sequencing, the families would come in, we'd have a meeting set up with their primary oncologist, our study genetic counselor, maybe someone else from our study team. It was another visit, it was another thing for the families, right? But then progressively been backing off to like trying to do that virtually, or trying to figure out for patients where the sequencing does not have any clinically relevant information, providing a kind of a lay summary of that by mail and seeing if that's sufficient, knowing that they always have access and opportunity to ask questions about it. But really trying to balance how to, in the least invasive isn't the actually right word, the least challenging way for our families to get them the care and the information that they need, knowing that pediatric oncology care is obviously, and amongst everything else, a complete logistical and operational disaster / challenge for our patients and their families, right? So how we can simplify this at all possible, I think telemedicine can be great.
Let's stay on that. Actually, I'd love to just, whether it's about telehealth or otherwise, talk about access and making sure that people who don't have ready access to the internet or a home computer or what have you can get quality care. Do any of you have any examples of things that are working at your own institutions to allow for that, to reach underserved communities, to reach populations who might live hundreds and hundreds of miles from one of your institutions, that kind of thing?
It's a great question. I can mention this. We're fortunate at St. Jude to be able to cover the costs for patients and families, and so we don't see cost being a huge barrier. But one thing that it is globally and it is across the country. We launched a few years ago a web resource called Together. It gets about 100,000 views a week, 100,000 users a week, that is all about educating patients and families about childhood cancer. You can type in your zip code, it'll tell you the nearest COG institution that is there. It's in 9 languages now, but it's exactly this, trying to provide an education for families and kids who are facing devastating diagnoses, diseases, really complex therapies, complex medical situations, providing them with the right information to help them ask the right questions of their doctors, wherever those doctors may be, whatever centers they are. But I think going forward, we really have to think about this. And globally, the disparities are even greater. As we look across the US, 80% cure rate, globally much worse. And so those are really important questions there as well.
Do you, just to quickly talk on that, Dr. Roberts, I know St. Jude Global has a lot going on. Any quick word you want to share about what's working to help bridge that gap globally?
Sure. So, as I mentioned, the greatest determinant of whether you will survive as a child with cancer is actually where you're born. So in developed countries, 80% cure rates, low and middle income countries, it's estimated to be less than 20%. And so that's a daunting endeavor. And so St. Jude Global was set up, works with the World Health Organization to try and provide education and training and global networks of teams where teach the teachers, build regional networks. We're investing enormous resources into this to go after what we think is the greatest disparity that remains. We had really, I think, important endeavors in Ukraine, helping evacuate the kids out of Ukraine by leveraging that network. But going forward, I'm excited about the impact, but it really is, for those of us who are pediatric oncologists, all of us on this call, it's a daunting challenge to think about outcome for kids elsewhere.
I think that the understanding of the impact on families extends well beyond just pediatric cancers. And so the concept of financial toxicity and the implications of financial toxicity because of a diagnosis of cancer is front and center, I think, of all cancer centers at this point. And so certainly within pediatrics, we have a lot of capacity through the generosity of donors, philanthropists, to help provide additional support beyond just what it takes to treat the cancer, because we care deeply about caring for the whole child and the whole family. But you have to recognize where that assistance is needed. And so that really recognition of the importance of financial toxicity, assessment of needs for each individual family that we're charged with caring for, I think is as important a concept as sequencing genes and matching to treatments. It's a precise approach to the care of the child and the care of the family that really has to start at all levels for the child.
Yeah,
those are all great points. I mean, I think one of the other things we've focused on here, for example, at Texas Children's, taking advantage of our very racially, ethnically, and sociologically diverse, population of Texas. A number of projects, including some, for example, that linking a couple of the key points we've talked about access and survivorship, right? So trying to understand how to not just provide access to molecular testing or to trials or to therapies, but to kind of effective surveillance, survivorship, and long-term care approaches for our, as one project, for example, our, Hispanic, Latino, and Spanish-speaking families, how we can identify specific barriers and facilitators of kind of survivorship services, and how we can address some of the knowledge gaps in various underrepresented groups and groups where we might not be as effective in terms of some of these interventions. A number of our faculty here, Michael Schur, Lisa Cayley, and Monica Gramachis, are leading a number of projects in this area, really trying to better understand how to provide long-term care for our pediatric cancer patients.
Dr. Lowe, did you have something you wanted to add in there on the?
Oh, just a bit. I'm again relatively new to Seattle, but learning a lot about the efforts that are in this area. And obviously, in the Northwest, we are also covering Alaska, Wyoming, Montana, and Idaho. And so there have been a lot of partnerships with oncology practices up in Alaska as well to sort of hybridize care a bit for super sick patients in Alaska coming down to Seattle. But, many of them are native, and it's really important for us to identify the specific areas that they need, both on a biological level, but also just on a needs, as Andrew already mentioned, the financial toxicity. Michael, I wanted to go back to one earlier point, if that's okay, because I've been looking at my phone because I'm embarrassed to say I don't know if this has been reauthorized, but in terms of trying to, fund initiatives for childhood cancer research, each of our institutions has very active foundations and development offices, some perhaps more active than others. But We also have federal methods, obviously, that have to support our work, And so the Childhood Cancer Survivorship Treatment Access and Research, or STAR Act, was submitted for reauthorization, I believe, at the end of April this year. I'm embarrassed to say, I don't think it's passed. It's went to both chambers of Congress. And so that's, I think, a $30 million ask to further research in all of those areas. And so anything that we all as a community can do to get behind that and support that passage, I think will obviously promote accelerations in our field. So I just wanted to mention that.
Yeah, thank you for bringing that back up. We have another question from someone in our audience. You all touched upon pediatric survivorship. Do you feel as clinicians that we're better addressing the needs of adolescent and young adults? And if so, can you elaborate on how that's happening for this kind of a population? Dr. Roberts,
Sure. It really begins with asking the questions about how are they doing, both on one-on-one for us as providers, but also systematically trying to understand what are the impacts on teens who have cancer, what are their impacts in the short term, and what are the impacts long term. And so I think we are doing better at asking the questions. Going into research studies, I mentioned the Childhood Cancer Survivor Study and St. Jude Life. Both of those pay attention to teens with cancer and the long-term impact. But I still think we have a long way to go. We know that chemotherapy and our treatments do both cause short-term and long-term negative impacts. Also, the psychosocial impacts on teens is different than for young kids and for adults. And so we have a big focus on providing support there, specific for teens, linking them to other teens who have gone through it before them. So I think these are really important principles that we all, I know all of us on this call think are important, and that we just have to keep focusing on doing even better going forward.
Oh, yeah. Sorry, go ahead, Andrew.
Will, after you.
Okay. I was saying, one of the key things, I think a lot of these topics end up being interconnected. So thinking back to kind of the pandemic, right? Like this has been one of the particular challenges that Zoe Dreyer and our members of our long-term survivorship team have been focusing on, how to continue to support our survivors and our young adults, for example, specifically during the pandemic. And so a lot of the initiatives that they previously had in person, really trying to create, amongst other things, kind of a sense of community amongst our survivors. So various social events, lectures, various touch points, a number of different ways, such that our former patients and current patients are able to connect with one another and with our teams have been really important. And they found using some of the same kind of telemedicine type virtual methods actually been remarkably effective at maintaining some of those connections during the pandemic. And so I think that's really one of the keys we've been focusing on, how to overcome any pandemic or other kind of isolation or challenges related to our adolescent young adult patients.
Yeah, I think the adolescent young adult population is a underserved age group. If you look at outcomes, if you look at the advances, if you will, in survival, it is clearly a gap. Now, why it is probably in part biology. The biology of the cancers that young people get is probably different than in older individuals, but it's also all those psychosocial determinants of health that are unique for this population may ultimately end up having similar sort of negative effects in terms of compliance, in terms of financial toxicity. Can you afford your meds? Do you actually participate in clinical trials? And so I do think that the AYA space is also a space that really depends a lot on us as pediatric oncologists partnering with our adult colleagues and making sure that we drive forward progress in this age group not only to better understand the biology that's common across the AYA cancers, but address those common psychosocial barriers to healthcare delivery. And so that is an area that I think many of our programs are actively growing.
Yeah, I could not agree more with what Andrew just said. I think when we think about survivorship also for our AYA patients, one can sort of think about it even in terms of a diagnosis, when they first come in to see us. So for example, one of our young investigators, Tyler Ketterl, has been instrumental in developing a fertility preservation program for patients who are of childbearing age, both for women and men. And that's key. Like that, you can't get there after you've finished all of your treatment. You have to sort of anticipate that as you start your therapy and balance that in. And I also agree with Andrew that having access, so again, I'll use the word access now, to this particular patient population, I think is also key. I would encourage, patients who are in that age range. If they are seeing an adult oncologist, they're probably great, but maybe request a second opinion from a pediatric oncologist to see if there might be a clinical trial that they might be eligible for, or a specific program that has wraparound services that may be available to them in their region. These are just some suggestions that we could provide.
Well, we're approaching our time, and I want to see if I can sneak in 2 more questions before we close. The first is another question from one of our audience members. They ask, how do you manage the mental and emotional health of patients and families? And I would tag on to that as well. A lot has been discussed about the community and collaboration among you all and oncologists more broadly. But how are you thinking about that for one another, for your colleagues, as burnout and stress and so many of those that's so profoundly affecting the healthcare industry? Anyone have, or a couple of you have a quick thought on that?
This really came to a crescendo during the pandemic, with such an impact on frontline providers, nurses, physicians, fellows, residents. Everybody had their lives turned upside down. Not only are they always worried about the lives of their patients, they became worried about the lives of their colleagues and their own. And so it became really important. We established our psychology team developed an internal support team to help our providers to think about this. And the same thing for families. Not only were they facing a life-threatening cancer diagnosis, but all of this happening in a time where they can't have the same freedom to move around, the same freedom to talk to other parents. And so this was where we did use telehealth, was to link families that have been through this before with current families, that I think is really important. And so that has been a major impact of the pandemic.
Let's ask one more question. I want to give you all the opportunity to weigh in. Misinformation, disinformation, the pandemic has obviously demonstrated this is a great challenge, especially around vaccinations. Do you see this as a challenge in pediatric cancer care? And are there things that you're able to do or that you don't have to do in that field to make sure that the proper information is getting out to individuals and families?
Well, I wish I could say that we were immune to this, but I think one of the great empowering changes that has occurred in medicine is actually the availability of information, but that information often doesn't come filtered for level of evidence, level of proof, and everything's very flat in terms of what you find on the internet in terms of level of evidence. And so there really, I think the best weapon against misinformation is a therapeutic alliance that you build by virtue of being there to listen to the question, answer the question maybe 5-10 times if necessary. And that's not just the doctor, but the nurse and the unit assistant checking you in. And that's really, I think, part of what it's always been about in terms of caring for a child with cancer and what it takes to be a doctor is that therapeutic trust. And that's more important now than ever before because of the issues of disinformation.
I think that's the most important point that Andres made about the therapeutic alliance. I will say, not so much in terms of disinformation, but different qualities or different quality of information is something that we have long experience with dealing with, right? And their roles as kind of the primary advocates for our patients, parents and family members often have things that they've read various places, a therapy that's been suggested by a neighbor or somebody else, or some information they've gotten. And it's our responsibility to, based on the trust that we've built with those families, to walk them through what we understand of the data and the logic for those sort of things.
And I think that through that therapeutic alliance, also making sure that the families know that we're a small community. We have access to each other. I feel totally comfortable emailing Will or Charlie or Andrew with a question. And I hope that they feel similarly comfortable emailing me. So when families realize that they're connected to a much larger organization and fountain of knowledge, it also can really help as well.
That's a great note to close out on. Dr. Roberts, do you have anything more to add?
No, I was just going to say, well said, Mignon. I think we do all have to come together as a team, and I think that's happening increasingly, and it's exciting to see.
Certainly is. From my perspective, I think that sense of community is very clearly on display with you all, and I appreciate the time you took today to share a lot of insights and perspective with our audience. Thank you to Dr. Will Parsons, Dr. Andrew Kung, Dr. Mignon Lo, and Dr. Charles Roberts. I want to thank you all in our audience for your good questions and your time and attention today. And just want to note again that today's program is the first in a summer-long series we're hosting on children's health. Later this month and next, we're going to examine caring for children with medical complexities, vaccine innovation and battling disinformation, and the power of community partnerships, picking up on a lot of the topics we talked about today. I want to encourage you to check out our full program lineup at usnews.com/pediatric priorities. Once again, thanks so much to our panel, to our audience, and to those listeners watching our video later. Take care.
Thanks, Michael.
Thanks,
See you
Michael.
later. Bye.
Thank you.